Imagine this scenario. EMS arrives with a woman who has just delivered a baby at home and is now bleeding profusely. Oh, hold on. The midwife that delivered the baby tells you that the patient had a long labor and delayed delivery of the placenta. The paramedics have started IV fluids, but the patient's blood pressure is still 60 over palp. You move the patient to a stretcher and you see that there is a huge pool of blood that has formed underneath her. Now the patient is becoming less responsive. Would you know what to do? Or what about this scenario? A pregnant patient twists her ankle and is triaged to fast track. Her blood pressure is 142 over 88. Do you need to do anything about that? Emergencies after 20 weeks are a scary and unfamiliar topic for most of us. You probably see early pregnancy emergencies on an almost daily basis on your shifts, but most of us rarely see patients in the second half of their pregnancy. And one reason for this is because many hospitals, including Georgetown and Washington Hospital Center, have protocols in place where patients past a certain number of weeks are triaged directly to labor delivery and not evaluated in the ED. But of course, these patients do end up in our emergency departments. And you as the emergency clinician are going to be expected to at least initially manage and stabilize the patients. So our roadmap for today, we're going to talk about two of the big emergencies that occur after 20 weeks, including preeclampsia and eclampsia and the management of postpartum hemorrhage. And for both of these complications, you will leave today with a 3-step ED management plan that you can apply to your very next shift should you encounter one of these disasters. So when it comes to the hypertensive disorders of pregnancy, what do we care about and when do we care about it? So you're used to thinking of pregnancy in trimesters. And I chose this picture because I thought it was just so representative of what pregnancy is like. Look at this beautiful woman. She's just growing her little flower and so light on her feet and her cute matching underwear. But no more. This picture isn't accurate for several reasons, but mostly because you're not going to think about pregnancy in trimesters anymore. For the emergency clinician, pregnancy has 2 halves. And that's before 20 weeks and after 20 weeks. And it is after 20 weeks that we always care about the blood pressure. I'm going to say that again. After 20 weeks, we always care about the blood pressure, and we continue to care about the blood pressure up until 6 weeks postpartum. And this is because it's within this time window from 20 weeks of pregnancy to 6 weeks postpartum that patients are at risk of developing one of the hypertensive disorders of pregnancy. Now, there are a lot of terms on this slide, and it's easy to get bogged down in definitions. So I would advise that when you're evaluating a pregnant patient after 20 weeks, just look for 2 things. You're looking for hypertension, and you're looking for signs and symptoms of end organ damage. Hypertension for a pregnant patient is defined as a systolic greater than 140 and or a diastolic greater than 90. And when we're talking about signs and symptoms of end organ damage, this is what we're referring to. And these are often sometimes called severe features as well. So you're looking for proteinuria, you're looking for thrombocytopenia, an elevation in the creatinine, liver function tests that are more than twice normal, a headache or new vision changes, chest pain, epigastric pain or right quadrant pain, and pulmonary edema. So if the patient's presenting after 20 weeks and the blood pressure is greater than 140 and or 90, you are going to investigate. You're going to investigate looking for any signs or symptoms of this end organ damage or severe features. And you're going to investigate by sending the following labs. You're going to send a CBC to evaluate for thrombocytopenia, a CMP to check the renal function and the liver function. You're going to send a urine protein and urine creatinine to look for proteinuria. And then also our OBGYNs at Georgetown and Washington Hospital Center request that we send a uric acid and LDH. Elevated uric acid can be a predictor of poor fetal outcomes, and it's associated with maternal disease severity. And high serum LDH correlates with severity of disease and poor outcomes in patients that have preeclampsia and eclampsia. So it's not so much for the diagnosis, but prognosticators that the OBGYN department asks that we send. And remember, after 20 weeks, we always care about the blood pressure, and it doesn't matter why the patient's in the ED. We still care. So even this patient that was triaged to fast track with a sprained ankle needs an investigation because that blood pressure is greater than 140. And we have to determine if there are signs or symptoms of end organ damage. Now, you're going to encounter some resistance here. This is your nurse in fast track after she sees that you ordered a CBC, a CMP, LDH, uric acid, urine protein, urine creatinine on your patient that had a sprained ankle, but you have to stay strong. And if you take anything else away from today's lecture, it's that you must respect hypertension in pregnancy. A well-appearing patient, even in fast track with a sprained ankle, could be standing on the edge of a cliff, and unless you dig a little bit deeper, you may miss this potentially life-threatening diagnosis. So commit to yourself now that you're not going to miss this, and you're going to investigate every time you see a pregnant patient more than 20 weeks that has a blood pressure of greater than 140 or 90. Now, what if you see a blood pressure of greater than 160 over 110? Now is when you're going to act. We investigate at 140 over 90, greater than 160 over 110 is the time that we act. That blood pressure automatically puts the patient in a severe category. So you're still going to send those same labs, but at the same time, you're going to be taking action. And here is your 3-step ED management plan. Step 1, you're controlling the blood pressure. Step 2, you're starting magnesium. And step 3, you're calling OB or arranging for transfer to an appropriate center if you don't have in-house OBGYN. So step 1, controlling blood pressure. You're going to treat any blood pressure that's greater than 160 over 110. Your goal is to stabilize the blood pressure around 140 or over 90. You're not aiming to normalize the blood pressure. And it's very important that you avoid hypotension, especially if the patient is still pregnant, as this can cause fetal distress. And remember too, that even though the patient may be swollen and have a lot of edema, the patient may be intravascularly volume depleted. So take a stepwise approach to giving your antihypertensive medicines. So which agents are you going to use? ACOG does not have a consensus on an ideal agent. All 3 of these agents are considered first line: hydralazine, labetalol, and nifedipine. And a few years ago, ACOG released this nice stepwise approach to treating severe hypertension greater than 160 over 110. This is in your handout, this chart that Jen Washington sent out yesterday, so you can refer to this there. But this gives you a stepwise approach for administering either labetalol, hydralazine, or nifedipine. Now, a couple of kind of hospital center specific caveats. The OBGYNs there prefer labetalol, and we actually still have a shortage of IV hydralazine. So most likely the patient would be getting labetalol in the ED. Nifedipine is a good oral option if it's taking a hard time to get IV access for whatever reason. But labetalol is the preferred agent, at least at Washington Hospital Center. And I think most of us are still dealing with an IV hydralazine shortage. So step 1, you're controlling blood pressure. Step 2, you're going to start magnesium. And magnesium is going to serve as seizure prophylaxis. Controlling the blood pressure alone does not prevent seizures. So all patients with those severe features or patients that have a blood pressure of greater than 160 over 110 should receive magnesium in the ED. Giving magnesium as seizure prophylaxis cuts the risk of seizures by more than half. And the dose is going to be 4 to 6 grams IV over 20 minutes, and then starting a 1 gram per hour infusion. And another kind of ordering caveat here in the ED, most of our EDs stock magnesium in 2 gram doses in our Pyxis. And so if you were to order 4 grams, that might delay the patient care because it would have to come up from pharmacy. So consider ordering 2 grams times 2 to get your 4 grams. That can be taken directly from our ED Pyxis to speed up patient care. Now, what if the patient seizes? Magnesium is still the drug of choice here. It's been shown to be better than diazepam and phenytoin at controlling eclamptic seizures. If you've already given that 4 gram dose, you can give an additional 2 grams. If the patient hasn't received anything yet, you can start right off the bat with a 6 gram IV bolus, and you can keep repeating the 2 gram bolus until the seizing stops. And usually eclamptic seizures are brief and self-limited. And so if the seizures are ongoing, this is a patient that you really need to consider obtaining a head CT on, because it's very likely that there might be intracranial hemorrhage or another complication that's causing the seizures to persist. So we've talked about controlling the blood pressure. You're going to start magnesium, and step 3, you're going to call OB or start working on arranging a transfer if you're not at an institution that has on-site OB. And I think preeclampsia and eclampsia is a really interesting diagnosis because it's actually one of the oldest recognized medical conditions in human history. Even the ancient Greeks knew that a headache in pregnancy was an ominous sign, but still thousands of years later, there is only one definitive treatment, and that is delivery. So when you engage OB, what is their management going to be? If the patient is term, they're going to recommend delivery. If the patient is preterm and there are no severe features present, they may elect for expectant management. But even if the patient is preterm, if there are severe features, severe range blood pressures, usually they're going to recommend delivery. Now, you might be wondering about EMTALA. If you're having to transfer a patient because you don't have the appropriate OB facilities at your shop. So EMTALA, as you know, was written with pregnant patients in mind. It stands for the Emergency Treatment and Active Labor Act. So according to EMTALA, a patient that is pregnant that is having true contractions is considered unstable, and actually not considered stable until not only the baby is delivered, but the placenta is delivered as well. Now, that doesn't mean that you can't ever transfer a patient that's having true contractions. You can if you feel like there's time or if the benefits of transfer outweigh the risk of keeping the patient at your shop. If the patient is not having true contractions, preeclampsia, eclampsia is treated like any other emergency condition, and once the patient is stabilized, you can arrange for an appropriate transfer. So we've talked about our pregnant patients so far. What about our postpartum patients? Remember, we care about the blood pressure after 20 weeks and up to 6 weeks postpartum. And these are actually the patients that we in the emergency department are most likely to be taking care of. Because once you have a baby, you're in the hospital for 2 midnights and then they send you home. And you're not planning on following up with your OB until your 6 weeks postpartum check. So if a newly postpartum patient has any trouble, they're probably going to be referred to the emergency department for evaluation. So how will the postpartum patient with preeclampsia present? Well, it's very similar to the antepartum preeclampsia presentation with one exception. In the postpartum period, headache is by far the most common presenting symptom. 62 to 80% of patients will present with a headache in the postpartum period, but they can have any of the other signs or symptoms of end organ damage like vision changes, shortness of breath, chest pain, nausea, vomiting, epigastric pain, right upper quadrant pain, or swelling. As far as treatment, obviously for your postpartum patients, delivery is not an option, but otherwise treatment is the same as the antepartum patients. So you're going to control blood pressure, you're going to start magnesium, and you're going to talk to your OB/GYN team or work on arranging a transfer if they're not in-house. Now, a couple of caveats. You might wonder, well, what about a patient less than 20 weeks? Is it possible for them to develop preeclampsia or eclampsia? And the answer is yes. It's very rare. There are some case reports. Usually it's associated with an abnormal pregnancy, so either a molar pregnancy, pregnancy complicated by antiphospholipid syndrome or triploidy. The last time I looked through the literature, I could only find 2 cases of what they call pure preeclampsia that occurred before 20 weeks in an otherwise normal pregnancy in an otherwise healthy mother. So very rare. So in general, it's not something that we're going to be encountering in the emergency department. I would say that a more likely scenario, and this is a potential pitfall for us in the ED, is that we're working with bad dates. So for a patient that maybe didn't have prenatal care, maybe didn't even realize they were pregnant until they're in the emergency department, the more likely scenario is that the dates are off and the patient is actually farther along in their pregnancy than maybe we realize. And so when you're evaluating a patient, it's important to ask, how are we dating this pregnancy? Did that patient have an early first trimester ultrasound, which is the most accurate way to date the pregnancy? Or are you using LMP? Are you performing a bedside ultrasound right there in the ED to try to determine dates? And remember that can be off. The accuracy of ultrasound as far as dating a pregnancy decreases as the pregnancy progresses. So as a general rule, if you're ultrasounding a patient in the 2nd trimester, your ultrasound can be off by plus or minus 2 weeks. And if you're ultrasounding a patient in the 3rd trimester, your ultrasound can be off by plus or minus 3 weeks. So the more likely scenario is that the patient is actually farther along in their pregnancy, is in fact beyond 20 weeks, and we might just be working with inaccurate dates. So try to drill down how that patient is dating their pregnancy. Did they have an early first trimester ultrasound? And if you're ultrasounding that patient for the first time to try to determine dates, recognize that your dates can be off by even up to 3 weeks if the patient is later on in their pregnancy. So what about this scenario? Well, the patient says, my blood pressure is always high. Do you have to worry about that patient? And the answer is yes. Patients that have chronic hypertension still can go on to develop preeclampsia or eclampsia. In fact, they're at higher risk because pre-existing hypertension is a risk factor for developing preeclampsia and eclampsia. So the safest thing for us in the emergency department is to assume that's a new blood pressure, even if the patient says they have a history of high blood pressure. This can be very tricky to tease out. Remember, people do entire fellowships in maternal fetal medicine to understand and to tease out these very small subtleties in these diagnoses. So the safest thing for us, even if the patient says my blood pressure is always high, assume it's a new blood pressure reading and treat it the same as you would. So investigate, send your labs, and if it's in a severe range, take action. Now, you might be wondering too about disposition. Can anyone go home? and possibly a select few if the patient has only mildly elevated blood pressure, so less than 160/110, and all of their labs are normal, and you've talked to their OB, then potentially those patients can go home with timely follow-up with their OBGYN. But for the most part, these patients are going to be hospitalized. Preeclampsia is a very unpredictable disease, and the initial presentation does not necessarily predict the likelihood of progressing to one of the more severe forms. And if the patient has severe range blood pressure greater than 160/110, generally they need to be admitted, regardless of their labs. So next, we're going to talk about the management of postpartum hemorrhage. So there's never been anything easy about delivering a baby, ever. But even though childbirth has advanced quite a bit from these times, women still die giving birth. And in fact, in the United States, maternal mortality is actually on the rise. And so what causes these deaths? Well, worldwide, the leading cause of death is postpartum hemorrhage. It's estimated that around the world, 1 woman dies of postpartum hemorrhage every 4 minutes. And sadly, it's estimated that 90% of these deaths would be preventable. Now, you might be thinking, I'm never going to see a case like I described in the beginning of a person coming from home and bleeding profusely. I work in a hospital that has on-site labor and delivery. But don't let that give you a false sense of security. In the United States, every year, 35,000 births take place outside of the hospital. And if something goes wrong with those births, the patient's not going to go to a labor delivery right away. They're going to call 911, and they're going to be brought directly to the nearest emergency department. And you as the emergency clinician is going to be expected to at least initially manage and stabilize that patient, whether you have in-house labor and delivery, OB, or not. So what defines postpartum hemorrhage? There are actually several definitions, the most traditional being loss of more than 500 milliliters of blood in a vaginal delivery and loss of more than a liter of blood during cesarean section. But it turns out that it's very difficult to qualify blood loss during delivery, and if anything, we tend to underestimate it. So a more practical definition I like is blood loss significant enough to cause signs and symptoms of hypovolemia or that requires intervention. So there are 2 types of postpartum hemorrhage. Primary postpartum hemorrhage occurs in the first 24 hours following delivery. Secondary postpartum hemorrhage is 24 hours up to 6 weeks postpartum. And today we're just going to be talking about primary postpartum hemorrhage. So a helpful way to remember the causes of primary postpartum hemorrhage are to think of the 4 T's. T for tone, this refers to uterine atony. T for trauma, referring to vaginal lacerations, hematoma, uterine inversion, or uterine rupture. T for tissue, referring to retained placenta or invasive placenta. And the last T is for thrombin, referring to coagulopathies. But the most important one to remember, and the one for which you will treat empirically, is uterine tone. So the uterus is a really interesting organ because it actually has its own mechanism for hemostasis. And that is these myometrial fibers that run in different directions and clamp down following delivery. And it's critical that this clamping down happens because at term, blood is flowing to the uterus at the rate of ½ a liter per minute. So if the uterus doesn't contract down, there's essentially a fire hose of blood pouring out. A uterus that hasn't properly contracted down has been described as having a boggy feel, and there is a risk that whenever the uterus gets tired, such as in a prolonged labor or delayed delivery of the placenta, or anything that causes overdistension of the uterus, such as a twin or a triplet pregnancy, can increase the risk of an atonic uterus following delivery. So if you find yourself managing a case of primary postpartum hemorrhage in the emergency department, there are 3 things you're going to do. Number 1, you're going to aggressively treat for uterine tone, uterine atony by beginning vigorous uterine massage. Step 2, you're calling everyone, and step 3, you're going to start meds. So step 1, the very first thing you're going to do is assign someone to begin uterine massage. And this is their only job. They stay at the bedside and keep massaging this uterus. You can do this externally first by placing one cupped hand in the lower uterine segment just above the pubic symphysis. The top hand is placed on the uterine fundus. The top hand is going to massage the uterine fundus in a continuous circular motion while the bottom hand holds firm pressure. And you should feel the uterus begin to contract between your hands. So this is step 1, assign someone to begin vigorous uterine massage. This is their only job. They stay at the bedside and they do not leave until they feel that uterus begin to contract down and the bleeding slows. Now, another way to massage the uterus is by bimanual uterine compression. One hand is external and one hand internal, pushing the uterus together and squeeze. So step one, you've assigned someone to begin uterine massage. Now step two is to call everyone. So who are you calling? Well, you're calling OB, obviously, but you're going to also call the blood bank. You're going to call interventional radiology if you have them. And if you're at a shop that doesn't have in-house OB, you might consider calling general or trauma surgery or someone that could potentially take the patient to the OR if things are going badly. So calling OB, obviously, and step two, you're going to call the blood bank. And why are you calling the blood bank? You're calling the blood bank at a minimum to order 2 units of uncross matched blood. And you're going to have a very low threshold for initiating your hospital's massive transfusion protocol. And just pull the trigger here, just order blood right off the bat. I've reviewed a few cases, medical legal cases of postpartum hemorrhage, and a general theme is an underreaction by the emergency team, not recognizing how bad the bleeding was or how bad the bleeding still is while the patient's in the department. So automatically order 2 units of uncrossed matched blood at a minimum and very low threshold for initiating the massive transfusion protocol. Who else are you going to call? If you have IR, give them a call. They may be able to offer arterial embolization, specific uterine artery embolization, which can help control hemorrhage and actually has little effect on future fertility. And finally, you can call a general surgeon or a trauma surgeon. And they might be helpful for you in this situation if you're working in a hospital that doesn't have an in-house obstetrician. And I have worked in a hospital that doesn't have an in-house obstetrician before, and I try to imagine how a nightmare scenario like a massive postpartum hemorrhage might play out in a hospital setting like that. So if you don't have an in-house OB, think of calling a general or trauma surgeon, anyone that can take the patient to the OR for a laparotomy, and they can offer several other temporizing actions such as packing the pelvis, cross-clamping the uterine artery or ligating the uterine artery, or even performing potentially a hysterectomy if it's truly life-saving. So you've assigned someone to begin vigorous uterine massage, you're calling everyone, and then now you're going to start your meds. So you're going to start uterotonics, and the first line uterotonic drug to reach for is oxytocin. Oxytocin is given routinely by obstetricians in the 3rd stage of labor as prophylaxis against postpartum hemorrhage. The dose is either 10 units IM or 30 units diluted in half a liter of normal saline IV. And you want to avoid a direct IV push of oxytocin, as this can cause hypotension and potentially cloud the clinical picture. And oxytocin is in the Pyxis at Washington Hospital Center and Georgetown. And the second drug I would reach for is misoprostol. I like this drug because it's also in the Pyxis, and the nurses are familiar with it as we give it frequently for other obstetrical complications like miscarriage. And you can give this drug many different routes, but probably the best way in a sick bleeding patient is rectally, and your dose is going to be 1,000 micrograms. Now, another drug that you might consider is TXA. The Woman trial was released in 2017, and it was a randomized double-blind controlled trial of over 20,000 women throughout the world using TXA, and it showed that it reduced death due to bleeding with little to no adverse effects. And now, right now, currently ACOG is not recommending this as a prophylaxis against postpartum hemorrhage, but it's a drug that we can consider if other medicines and other techniques have failed. And this is something I absolutely would consider reaching for, especially if I was in a hospital that I potentially might have to transfer the patient, or there might be a delay until a surgeon or an obstetrician could take the patient for definitive treatment. So something else to remember, in our toolbox, the dose is going to be 1 gram IV, and ideally, like our trauma patients, you try to administer it within 3 hours of delivery, if possible. So you have your 3-step approach. The good news is that the majority of the time, aggressive uterine massage, resuscitation, and meds will be enough to at least stabilize your patient. However, if the bleeding is continuing despite these efforts, there is a possibility that something else could be going on. And this is when you're going to return to the remaining 3 Ts. So you've already empirically treated for uterine atony by aggressive uterine massage. Your next T is for trauma. So you're going to get a good light source and thoroughly inspect the entire perineum for tears. The entire perineum. Now, this is an example. This mother does not have any significant lacerations or tears. And you'll note this is almost immediately post-delivery. There's really not that much bleeding. There shouldn't be much bleeding after a normal delivery. There's an initial gush, and then it pretty much tapers off and stops relatively quickly. So this was a mother with no significant lacerations or tears. In addition to tears and lacerations, you're going to be checking for hematomas. Vulvar hematomas are fairly obvious, But deeper vaginal wall hematomas can be more subtle, and a large amount of blood may be accumulating in a potential space within the pelvis. Now, a pearl here is that deep vaginal hematomas can present as intense anal or rectal pain. So if the patient is complaining of severe rectal or anal pain, and you didn't see any large anal or rectal lacerations when you did your thorough inspection of the perineum, you might suspect a deep vaginal hematoma. And if the patient is stable, this can be diagnosed on CT. So we've talked about uterine atony, you've done your thorough inspection of the perineum for trauma. Next, you're going to examine the placenta to see if there's any pieces missing that it could indicate there's retained placenta or invasive placenta. So you're going to look at the placenta, check to see if it's complete or missing any parts. If it looks like a chunk is missing, you may need to do a manual sweep of the uterus. And so this is an intact placenta, no pieces are missing. But if you do feel like a piece is missing, you might need to do this uterine sweep to remove any of the leftover pieces. So to do that, you're going to put on a sterile glove. You're going to insert one hand into the uterus, keep your fingers cupped tightly together. You're going to find the margin of the placenta where it meets the uterine wall and gently slide your fingers behind the placenta to detach it. Now, your external hand should be applying pressure to the lower uterine segment when you remove your hand to stabilize the uterus and to prevent uterine inversion. You can perform a second sweep to ensure that the uterus is empty. And then after your second sweep, you're going to perform aggressive uterine massage to stimulate uterine contraction. Now, the final T to consider is thrombin, or the possibility of a coagulopathy. So if there is concern for an underlying bleeding disorder, consider sending a DIC panel. Now, despite all of your efforts so far, additional temporizing measures may be necessary, especially if you have to transport the patient for definitive treatment by an OBGYN. An option to consider is uterine balloon tamponade. A commercial device exists that's called the Bakri balloon, and this is essentially like a giant Foley catheter. It's inserted through the cervix into the uterus and inflated with up to 500 cc's of saline. Now, it's unlikely that you'll have ready access to a Bakri balloon in your ED, especially if you're working at a hospital that doesn't have in-house OB or labor and delivery. So there is a low resource way to create the effect using a Foley catheter and a condom or one of our old transvaginal probe covers. So this is a good just trick to keep in your back pocket. So using a regular Foley catheter, a stopcock, you're going to have a hemostat and some suture tie, just silk sutures. You're going to insert the Foley catheter into the condom and then tie it off with a suture. And then you're going to insert this into the uterus. And next you're going to instill water through the Foley to inflate the condom. And this can hold at least 500 cc's, similar to our Bakri balloon, and possibly even more. And you're going to keep instilling water. The water is filling up the condom. And keep injecting water until you have tamponade. And then you're going to insert just a little stopcock in the end of the Foley so the water doesn't leak out. Alternatively, you could use your hemostat to clamp it off too. So as you're instilling the water or the saline into the condom, it's inflating and will act as a tamponade device, similar to the Bakri balloon, but the low resource version. And then finally, another option is uterine packing with continuous gauze. Uterine tamponade devices, the Bakri balloon, the condom catheter, Foley, or packing can remain in place for up to 24 hours. So to summarize our three-step approach to postpartum hemorrhage, begin aggressive, vigorous uterine massage. You're calling everyone, you're calling OB, you're calling the blood bank, you're calling IR, you're calling a general or trauma surgeon. You're going to start your meds, oxytocin and misoprostol, I would recommend as your first two drug choices, and they're both in our Pyxis. Consider TXA, and then also consider your other Ts and consider a temporizing measure such as uterine balloon tamponade. And just to summarize everything all together, we always care about the blood pressure after 20 weeks. You're looking for hypertension plus signs or symptoms of end organ damage. You're going to control blood pressure, you're going to start magnesium, and you're going to call OB to arrange for transfer if necessary. And for postpartum hemorrhage, your three-step approach, aggressive, vigorous uterine massage, calling everyone, and starting your uterotonics. And that's all I have. Thank you.
Great, Joelle, that was fantastic. We have a lot of content to cover, but I do see one question that I'm wondering if you can address real quick, which is about the blood pressure and the blood pressure target in one who, whether or not it's the same for people with or without a history of hypertension.
So patients that have a pre-existing history of hypertension.
Yeah.
Yeah. So again, you want to stabilize around 140 over 90. We're not aiming to normalize the blood pressure, but generally you want to keep it less than 160 over 110. And for the patients that have a history of chronic hypertension, I mean, I would really engage your OB consultants early, because this is complex and it's hard to tease out. And remember, people do entire fellowships in maternal fetal medicine, trying to tease out these subtleties. And when patients are getting worse, when it's progressing from their chronic disease to now a new preeclampsia diagnosis. So these are the patients you're going to want to talk to OB very early to get their recommendations and guidance, because it can get complicated.
Great. One last question and then we'll move on. Does the balloon tamponade interfere at all with the uterus contracting down?
Yeah, so this would be something that I would try after you've tried your aggressive uterine massage. You've tried to get the uterus to contract. So at this point, for whatever reason, it's not contracting down enough. And so I think that's when the balloon tamponade is an appropriate device, because for whatever reason, the uterus just isn't contracting enough. So it's going to help stabilize and temporize until the patient can get more definitive treatment. These might be patients, for example, that have like invasive placenta accreta, placenta percreta, that definitely need to go to the operating room. So this would be more of a temporizing measure until they can get that definitive treatment, usually in the OR.
Okay, Joelle, again, thank you very much. That was fantastic.